Hello, Dr. Myers. So happy to have you here. I think I have a very relevant topic to discuss with you, which is perimenopausal, postmenopausal, menopausal health. There's so much stigma, there's so much misconceptions, there is just too much going on. Should we take hormones? Shouldn't we take hormones? What are the damn symptoms? I think everything is a big, big conundrum. So I'm looking forward to this conversation because I want to learn about this and I want to know what I should be looking for and what we can do together. So thank you so much for coming
Thank you
today.
for having me. Such an honor. So, I am happy to answer all those questions. And if you're feeling confused about this phase of life, it's so very common. I mean, 2 decades of physicians have been undereducated because of the WHI. It leaves patients wondering what to do, getting misinformation through social, doing their Google searches. I mean, a study just came out of the UK showing that on average, individuals go to 10 of family practice or GP, they're going to their general practitioner trying to get some answers in regards to perimenopause and menopausal symptoms. This is not unique to women in the US. I hear this all the time, all day long. So when that came out, I was like, I mean, it's worldwide. Like everyone is suffering.
And they don't talk about it. I think, even in medical school, I don't remember learning a whole lot about it. And, but once you go into internal medicine residency, you're completely cut off. So unless you are OBGYN like yourselves, like specializes in men's
Yeah.
perimenopausal or menopausal health, the knowledge gap is quite
Well,
vast.
and I think it's even beyond that. I mean, a recent study came out indicating that of the programs, of the OBGYN residency programs that had a menopause curriculum, it was 4 or fewer lectures. So, on average, a lecture a year, I mean, that's not a lot of hands on clinical evidence. And that's why we're seeing now there's a big menopause movement. Women are demanding more. Clinicians are hearing them, realizing that they're not adequately trained, and now are getting certified in menopause medicine through the Menopause Society. At the menopause meeting this past year, they said they had more signed up to take this next test to be certified in menopause
Mm.
medicine than had certified in the previous year. So
Oh,
we have
wow.
to keep being loud. We have to keep demanding our expectations in the healthcare system, and the system will change. So practitioners are responding, and I'm really excited to see this. I feel like I'm an old timer at this because, I opened my gynecology practice in the middle of the pandemic after, working full time as an OB hospitalist. And that was after, a couple years stint of really taking some time to focus on my family and doing only hospitalist shifts. And then them coming along and saying, you're going to have to be proctored, you don't have enough volume, etc. And so me going back to say, oh, I can do this. I can still do this, right? I've got the volume, working nonstop in the system in the middle of COVID where everything changed. And now we're not going to have 2 doctors. We're going to have, one at night and a midwife. And so I just found myself in the height of COVID completely overwhelmed and burnout in the system, feeling like
Mm.
I know that I deserve better as a physician. I am not a robot. I can't work 24 hours every other day. And
Yeah,
I know that women want more. And so when I opened my
absolutely.
gynecology practice, it was more because I wanted quality time with my patients and I wanted quality of life, right? And so this is kind of my health reboot where I was like, I deserve better and so do my patients. So how do I optimize sleeping in my own bed and really taking quality care of patients? And unfortunately, that can't happen in our traditional healthcare system where we're taking insurance because insurance does not value preventative care. They do not value the quality of care that we're providing to patients. And so I opened a gynecology practice really thinking that my osteopathic skill set was going to be my secret sauce. But what I heard from women over and over and over again, while yes, my OB colleagues send their patients to me for their pregnancy, back pain, and pelvic pain, I'm nobody's primary OB. So I really have the time and space to focus on women in this phase when they're done having babies. They don't want to spend half a day at the OBGYN's office trying to get their annual exam and discuss their perimenopausal symptoms. And so the demand is there to the point that I said, I want to feel more of an expert. And so I got menopause certified 3 years ago. And so to answer your question, I have this discourse back and forth with not only patients, but with women physicians day in and day out who are so confused about perimenopause and menopause, and confused even about what the experts are saying, because they're getting their information from social, and it's short little clips in social, and it doesn't always tell the whole story. So I'm so excited to be here today to really dive into this.
So, I think you kind of answered a question, which is a reboot in your life. And it was truly COVID, I guess. And, there's no healing for the healers, unfortunately, in the current medical system. And so many of us have taken drastic changes in our career paths because the administration does not seem to care about the doctors, the nurses, the healthcare
Yeah.
providers at all, which is a very unfortunate situation. Well, that's a discussion for another day. So let's come back to menopause,
Yeah.
or actually
Yeah.
perimenopause. What age does it start?
Okay, so let's start with some clear definitions. Okay, so the average
Mm-hmm.
age of menopause is defined as 12 months without a cycle with no other cause. So a natural decline in that, or it could be surgically, you could be surgically menopausal, right? If you've had a hysterectomy with removal of your ovaries. But on average, this natural menopause happens around the age of 51. Now, that may
Okay.
be confusing to individuals if they say, well, I've had an IUD, a progesterone producing IUD, and I don't have a cycle, or I had an endometrial ablation and I'm not having a cycle, or I had a hysterectomy and I preserved my ovaries. So then at that point, you would, go through the natural menopause. So I'm not having a cycle. How do I know I'm menopausal? Right?
Mm-hmm.
Fair question. So, in those particular instances, you're probably going to be having symptoms because perimenopause happens before that. If we have an average age of 51 of menopause, then we're going to see symptoms in our 40s and sometimes late 30s for perimenopause, because
Oh, wow.
perimenopause on average lasts 7.4 years. It can last 10 years in women of color.
Oh, wow. These are, I'm getting blown away by these facts. So, average onset is 7.5 years. That's a long time. What are the symptoms in this time?
That's a very fair question. That's what everybody wants to know. Hot flashes, night sweats, mood swings, difficulty sleeping, vaginal dryness, urinary urgency frequency, even incontinence, changes in periods are some of the most common, like early symptoms that we see, whether they're longer, shorter, closer together, heavier. They can kind of be all over the place. Trouble concentrating, trouble with memory, so that brain fog, low energy, kind of a lack of drive for life, low sexual desire, painful sex, aching joints, breast pain, thinning hair, racing heart, weight around the abdomen, bloating, depression, anxiety. What does it not touch? We have estrogen receptors
Yes.
throughout our body. So there are so many symptoms of perimenopause. And just because you're menopausal, just because you've had your final menstrual period, does not mean that your symptoms end. Some women continue to be symptomatic even beyond 65. And so then the question is, well, what do we do? So before we talk about treatment options, I really want to address some of these symptoms, because what happens so often in perimenopause is that women aren't feeling themselves. Like, I just don't feel myself.
Okay.
They may be at the height of their career. They may be busy parenting. They may be sending kids off to college, or they have aging parents, and they're kind of sandwiched in with all of the stresses of adulting. They're finally like in their own in their 30s and early 40s, right? They've like gotten used to their rhythm in life, and all of a sudden they don't feel themselves. Whether it's that lack of drive, whether it's that brain fog, whether it's the hot flashes and the night sweats and the poor sleep, therefore we're not making good food choices, or it's body distribution, and all of a sudden our pants don't fit. It's all of these things collectively where they just don't feel themselves. And so with well-intentioned, as we talked about earlier, they go to their family practice doctor, their internal medicine
Mm-hmm.
doctor, their GP if we're abroad, and they're looking for answers. They may even be going to their OBGYN, not knowing that their OBGYN really has very very little training in this area and is so busy delivering babies most of the time that they don't have the time to really give this the attention that it deserves. And so they get their lab work done and they hear, your labs are fine. You're fine. Everything looks fine.
Sounds like a story I've heard a million
Right.
times.
Right. And the patient leaves going, well, I guess it is all in my head, but I don't feel fine. So how is that, right? Well, perimenopause is a clinical diagnosis. I don't have to have your hormone levels to know that you're perimenopausal. It's your collection of symptoms, looking at those other health concerns, right? So we have, some 50 hormones or more in our body. It's not just sex hormones. We always think it's our sex hormones, but perhaps we have a thyroid disorder. Perhaps we have insulin resistance, right? So we do have to look at the bigger health picture, that holistic health. But when we've ruled out other causes and all of these collection of symptoms are present and we're in that age category, it's like, yeah, this is perimenopause. So it's really having a detailed conversation with your provider. And people may say, well, I've gone to my provider and I got the you're fine message, right? Where do I go? So you can go to menopause.org. So you can go to menopause.org and find a Menopause Society certified provider in your area. You can put in your zip code.
Okay.
Now, it's imperfect. The website lists individuals who are members. I don't think a member is equivalent to somebody who's certified. So that distinction tells you that they've studied additional information to pass the exam, that they're maintaining their continuing medical education in this field and staying up to date with the latest in research. However, I did have somebody reach out the other day to say, well, I did that and found somebody in my area and they prescribe pellets.
So let's go back one step, and I want to summarize this. So perimenopause, number one, is not a lab diagnosis. So you don't need to get your hormones levels checked to get a diagnosis of, oh, you're in perimenopause. It's more of a collection of symptoms, which basically goes from head to toe. And it comes from a detailed conversation and physical exam. And the labs might be done to rule out other causes.
Correct. You got
other
it.
confounding factors. Okay. So that's number one. Okay. Menopause is easy to diagnose. As you said, if you don't have a cycle for 1 year or 12 months in the absence of surgery or anything of that sort, okay, you are in menopause. But the symptoms of perimenopause can extend even after you have attained menopause.
Yeah, just because you've gone through menopause doesn't mean that you're not going to have hot flashes or night sweats anymore and that you're going to sleep wonderful, right? Because it is an estrogen deficient state. Our ovaries we have a chronological age, but we also have that ovarian age. And those ovaries are no longer producing the estrogen, testosterone, progesterone. So we have a deficiency that impacts our entire being. And so treatment options are available, and that's really exciting to talk about.
Let's go there. Yes, you've depressed me right now. You have to give me some options now.
Okay, so we have non-hormonal options for hormone therapy. And, I host a women's health podcast called Sky Women's Health, exactly as the name of my practice. It's meant to be an extension of these conversations that we have in the exam room that discusses.
And we'll put those links of all of that in our show notes. So anyone who wants to reach you should be able to reach you through our show notes.
Perfect. So non-hormonal options can include anything from cognitive behavioral therapy, SSRIs, which we typically see used for antidepressants, hypnosis, gabapentin, which has its own set of side effects, right? So there definitely are other options that you want to do. And in that episode, I go through all the things that actually, what hasn't shown to be effective.
Yeah, like briefly, why will cognitive behavioral therapy help with hot flashes or sleep disturbance or something like that?
Right. So I think that it is more how we think and feel about our experience and what's happening, because I have that same question, right? How is that? However, individuals tell me when they're more stressed, when they're anxious, their symptoms are worse.
Okay, that's for every disease in the world.
Right, right. So that's
Yeah.
where we get into this functional medicine or holistic medicine where we take the whole person, mind, body, spirit, right? We can't differentiate those. Like it's all interconnected. And so yeah, I think cognitive behavioral therapy helps for all things.
Yes, I mean, I know AFib patients who have less episodes of atrial fibrillation if they do cognitive behavioral therapy, but that is not a cure for atrial fibrillation. It helps control the
Exactly,
symptoms.
exactly my point. So, with our non hormonal options, if patients are wanting to avoid hormones, then these are some options that we can provide. Now, I will tell you worldwide, women are sick and tired of being put on antidepressants for their hot flashes and never being offered hormone therapy.
Because even SSRIs, right? Because I'm like, I'm not depressed. I'm having a other problem. I'm perimenopausal or whatever. Let's treat that instead of treating depression. I mean, it's like kind of
Yeah.
a long route to
Right. Well, I mean, there is evidence for it, and so that's why it's one of the recommendations.
okay.
However, we also know that we see more agitation, anxiety, depression, especially if there's a history of mood disorders. But guess what? In perimenopause, if we replace their estrogen, it oftentimes works just as well as an SSRI. I do also want to mention that there's another drug, Veosa or
Hmm.
fezolinetant, that is an oral medication that works on the receptor in the brain that kind of modulates that thermostat, right? I always say it's like, the janky thermostat in the cabin that just, you can't move it one way or the other. And it just goes off. We're too hot, too cold, right? This is menopausal, like it's driving you crazy. You can't control that thermostat. And so Veosa is a non-hormonal option. It's a newer medication that's been all the rage in the last year that helps with hot flashes. And so if we have somebody who is absolutely not a candidate, say they're in active treatment of breast cancer and not a
Okay.
candidate, or they've had a recent heart attack, not a candidate for breast cancer, then Veosa may be an option for them to relieve their
Okay.
symptoms, because we know when people have multiple symptoms, vasomotor symptoms that are disrupting their sleep, they actually have more heart risk.
Yeah, I mean, estrogen is cardioprotective, right? That's
Yes.
why women have a later onset of disease of 65 or older, because that's when we are pretty much depleted of all estrogen in our body or something like that. So yeah, I mean, so we cardiologists like estrogen most of the time.
Yeah, right. A common question that
No
I get
doubt.
is then, so if they've had a cardiovascular accident or they've had a blood clot, if it's truly vasodilator and it's cardioprotective, then why can't they have the estrogen? Why is that a
So
contraindication?
it depends on what kind of cardiovascular event they had, right? If it's a heart attack, estrogen therapy does not make a difference. But if you've had a stroke because of blood clots in in your legs, in which crosses and goes off to your brain through a patent foramen ovale or a hole in the heart or something, then you're high risk for venous or clots in your
Right,
leg. And some of the oral estrogen therapies have higher incidence of venous
right.
disease. It's those patients, and I'm sure we'll talk about that in the oral versus transdermal
Yeah,
forms and stuff
yeah,
like that. But it's the oral therapy in those patients is when we are worried about it,
yeah,
you know?
yeah.
Yeah.
Okay, so let's get into that. So we talked about non-hormonal. Then let's talk about hormonal,
Yes.
since we're
Let's go to
addressing that
hormone.
estrogen. So when we're typically talking about hormone replacement therapy, which most people think about is estrogen, right? Estrogen and then progesterone. If you still have a uterus, we need to give you progesterone to keep your risk of endometrial cancer at baseline. So individuals who are
Okay.
on estrogen and progesterone do not have an increase from baseline for endometrial cancer. If you're just on
Okay.
estrogen, what we call unopposed estrogen, and you still have a
Hmm.
uterus, that nest starts proliferating, wants to build up, and then we get hyperplasia, we
Then
get
you get cancer.
precancerous cells. And I've seen this happen too many times where individuals have been on pellets or other high dose medications or not knowing exactly what hormone therapy they're getting, not getting adequate endometrial protection because they're doing the cream or the gel for progesterone, which is not absorbed, ladies. And then they get endometrial hyperplasia. Now, easily treated with, say, a hysteroscopy DNC, where we go in with a camera and we take a sampling of the lining of the uterus and make sure that we don't have any further disease there. And if it's just a benign hyperplasia, it can be treated with a progesterone IUD very easily, or oral progesterone.
I'm going to step back for 1 second. So, when you're talking about hormonal therapy, from what I know, which is very limited, you have oral medications, you have transdermal
Yeah.
patches, and then this new pellet thingy, right? Pellets which are implanted. So, can you start
Yeah.
there
So what I
and
was
kind of
doing is
go
kind of
from
giving
there?
you a big picture, right? So we have estrogen and progesterone, which are our buckets that most people generally think about. Okay. And then we also have testosterone. And I don't know if we have time to get into that, but testosterone also can be replaced in women and should be replaced in women when needed. So with our estrogen, we have different routes, right? So if our hormone therapy isn't working for us, it's either the dose, the route, or the formulation. Okay. So when we're talking
Okay.
about estrogen, typically we're talking about a bioidentical option that we can give women now. You also have conjugated equine estrogen, right? So we do have options in terms of formulation.
So, bioidentical is synthetic, whereas the equine is derived from
Right. But
horses.
what most people don't know is that they think in order to get bioidentical, because the marketing has been so fantastic on this, what they're generally thinking about are these compounded hormones, right? Compounded hormones are not safer than FDA approved bioidentical hormones. They're expensive. They're not covered by your insurance. You can get your FDA approved bioidentical hormones covered by your insurance from the pharmacy. And if they're not covered by your insurance, it's pretty inexpensive paying cash.
Why is there, what is the advantage of the bioidentical hormone? Why are the compounded pharmacies, why is that even a market if this is the case?
Because it sells, because the women's health initiative came out and scared everybody off of their hormones. And so they said, oh, here's a ploy. They've taken advantage of the lack of knowledge. And so in this void, here comes in these bioidentical compounding pharmacies, pellet therapies, etc. Okay, so when we're talking about estrogen, we said we have different options, right? So there's different formulations. There's also different routes. So you can take it by mouth. Most of the time, we're trying to avoid the oral route so that we bypass the liver, so that we don't increase your clotting factors. And so then that can be given via the skin in a patch or a gel or a vaginal ring. Now that gets confusing to some
Okay.
individuals because we have a low dose vaginal ring that's specifically for genitourinary syndrome of menopause. So the vaginal dryness, the itching, the burning, the urinary frequency. But we also have a ring now that is high enough dosing to be systemic. And so
Okay.
those are our non-oral routes for getting our estrogen.
And the advantage of that is it reduces the venous clotting risk for the patient.
Correct. And then we have progesterone. Progesterone is given either by mouth in an oral tablet that you take at night because it helps you sleep so well. So progesterone is taken at night and it can be taken in a continuous fashion. So every night, which I find to be best because most people who are in this phase of life are not interested in keeping up with tracking it and taking it 10 or 14 days out of the month and having withdrawal bleed possibly if they've still got some of their hormones on board. And so especially in perimenopause, we typically want like more management of those cycles. And so it certainly can be cycled. You only need those 10 days out of the month for endometrial protection at the appropriate dose of oral progesterone. Transdermal progesterone is in the bioidentical form, is not absorbed via the skin. It's too large of a molecule. And so we don't want to get it that way. Now, some people may say, well, there are patches that have the combo of estrogen and progesterone. Yes, that's true. And it would be a synthetic. It would be a different formulation. Okay. So in general, if we're talking about progesterone and we're going to take it by mouth, some individuals have progesterone intolerance and they need to actually place that micronized progesterone in their vagina. Okay. That's rare. Small number of cases have progesterone intolerance. And we can also do a progesterone IUD, a progesterone producing IUD like Liletta or
Like the
Mirena.
Mirena or something.
Works
Okay.
beautifully for cycle control. This is one of my favorite things for perimenopause. If you're having, periods all over the place, if the periods have gone off the rail, it's progesterone producing IUD is so nice to manage those cycles. Now, using it in this instance, I only use it for up to 5 years because its indication for heavy menstrual bleeding has not been extended to the 8 years, even though somebody who doesn't know better will tell you it's good for 8 years. It is for pregnancy
Hmm.
prevention. But to date, we don't
Okay,
have
okay.
data to indicate that it's going to be extended beyond that for endometrial protection. Okay. So that's our estrogen and our progesterone kind of in a nutshell. So you have
It's
options.
very complicated, just so you know. I'm a doctor and I'm like, oh my God, this is a very complex mechanism and there's a lot
Yeah.
going on here.
Here's the thing that, oftentimes patients are overwhelmed, right? Like they're so excited to have all
Yeah.
the information, but then they leave and they're really overwhelmed. And here's what I always tell them is I don't want you to leave with overwhelm. I want you to leave with excitement to know that there truly are options. So let me just give you a for instance. I had a lady who was in her late 50s who came in who had been on hormone replacement therapy since her hysterectomy in which her ovaries were removed. Yet she
Okay.
still has hot night sweats that are disturbing her sleep. And she's really frustrated because she went to her OBGYN multiple times saying, I'm not any better. I think we can do better. And he's like, this is all there is. And she said, well, what about us replacing our testosterone? And he got up and walked out of the room because he got up and said, this, we don't do that in the US, and left. No
Okay.
discussion. And that just comes from a lack of knowledge. So anyways, I come in, we have this detailed discussion about the ins and outs of hormone therapy. We understand that now she's using Divigel, which is the estrogen gel, and she's placing it on every morning. So before changing her route or changing her formulation, I said, what if we try dosing this at night since your symptoms are more
Hmm.
severe at night? So on her follow-up exam, which the magic happens in the follow-up, ladies. So if you are given a hormone therapy regimen and said, see you next year for your annual, run for the hills because the chances are it's not going to work and they don't have the time and the dedication or the understanding to make those edits with you. So she comes in for 8 to 12 week follow up and her symptoms are gone. So for 5 years, she's been on hormone therapy suffering. One little tweak to her hormone therapy and she's all better.
So this is very extremely nuanced. And I think I love that piece of advice you gave that you will need follow up in 8 to 12 weeks or something similar. And if that's not the case, that's not the right fit for you. That's fabulous. Thank you.
Yeah. Okay. So do you want to talk about testosterone?
Let's talk about testosterone. I'm overwhelmed.
Okay.
Oh,
You know
God.
what? So with testosterone, we don't have great research in testosterone, right? Because we've gendered these hormones. And so heaven forbid that we actually have an FDA formulated testosterone, right? For women specifically. Now, we all know that they would just put the pink tax on it and we would see the price increased if it were. So
Of course, yes.
testosterone can actually be replaced in women. Now, to date, the data tells us time and again that it helps with the hypoactive sexual desire disorder, so that low lack of drive in the postmenopausal woman. Anecdotally, though, patients tell me they feel clearer, they have more energy. Now it is not the cure all because what you see in all the hormone replacement therapy clinics on every corner where they're injecting pellets and you're getting weekly injections if it's not a pellet that's in there for 3 months, is that these women come in with super therapeutic hormone levels. So they may have a
Mhm.
testosterone in the 160s, 200s. Like, you don't need a testosterone level equivalent to your spouse or to a male. You need a normal physiologic female range. Now,
So, what is the normal physiological testosterone range? I have no
I
idea
know,
about that.
right? And I don't know that we actually know. Like, I think that it's going to
Ah,
change as we study this more and more, and we have more funds attributed to women's sexual health. But it's going to be dependent on your lab, like most lab
mm.
tests, right? My lab, I use Path Advantage, may have different normal values than Quest, right? So it's going to be dependent on your lab. And
So, one question about
mhm,
testosterone. So, part of the perimenopausal or symptoms is hair loss,
mhm,
right? And I know the androgenic male
mhm,
pattern balding, which
mhm.
happens as women grow older, is also hormone sensitive and testosterone sensitive. So, is the hair fall going to get worse because of the testosterone replacement?
So no, not when replaced appropriately. Okay.
Okay.
So testosterone replacement in women should be done with a transdermal gel. I typically use Testim in a screw top tube, and it is FDA approved for male use. The one little
Okay.
tube is one male dose. We dose women
Okay.
at 1/10 of the dose.
So it's just a teeny tiny
It's a
bit,
pea-size
and
amount
that's
to
it.
the thigh daily. And then we retest your
Okay.
values in 6 to 8 weeks after initiating it. Are we absorbing it? Are we applying it to correctly? Ensuring that we're not in a super therapeutic range, that we're not beyond our normal levels. And are we seeing a response? So typically I'll do a 12-week trial. Are we seeing a response? So when we're replacing to a normal physiologic range, there is very little adverse effects with testosterone use.
Okay.
And in terms of the hair loss that happens, oftentimes it's because of this redistribution of the hormone levels, and we have this lack of estrogen. So we actually have more testosterone in our bodies than estrogen. And so when we replace our estrogen, we're supporting hair growth, right? And
Mm.
so we don't want to be growing chin hair. We don't want to get acne, so those are the limiting factors when it comes to using testosterone. So using a little smidge to get us in a normal physiologic range is typically wonderful for most individuals, and they report that they're feeling much better. If their estrogen isn't replaced and they're coming to me after having a pellet and their testosterone's 175, they don't feel any better. They're still telling me
Yeah.
they've got hot flashes and they've got night sweats and they've got vaginal dryness and they're always fatigued. Everybody is unique. Transition off of pellets saying that they're tired of the roller coaster of like they'll feel really great and then it's here we go again. And so all to say that we know that testosterone can help in improving sexual pleasure, improving desire. That is what the evidence tells us to date. It is considered off-label use, right? But we do have evidence for it. We have a global
Okay.
statement. We have a practice pearl from the Menopause Society. So there is definitely evidence for its use. When we're replacing estrogen, progesterone, testosterone, whatever combination, it's just important that you have a good relationship with your healthcare provider who can help you to tinker and to just get this right for you. I always tell patients it takes generally 3 to 6 months for us to have them feeling great and back to their status quo. My goal is 90% better, if not 100. And we
Okay.
typically get there. There's always an outlier who it takes 18 months for us to kind of
Obviously.
find the right formulation, but most individuals don't come with a manual. I don't know exactly what to do for them. So it's just making a decision of what you think is going to fit your lifestyle, taking that first step in the right direction and giving it a try, knowing that edits can be made and you're not stuck.
So the other big point of this whole thing, which got is I'm 47, going to be 48, and I really wanted to go in a route away from the rest of the world. I want to bulk up. Okay, compared to getting super skinny, I actually want to get
Yeah.
muscular, and I want to, and I'm really that's how I even came about this, and how there is significant sarcopenia or muscle loss in your perimenstrual menstrual
Yeah.
thing. And I'm like, I'm wondering, I'm lifting heavier than before, but I'm not seeing a whole lot of bulking up happening. And then I was like, oh, you need to be on hormones. And I've truly avoided that whole thing because I'm like, oh, I just don't want to take meds. I'm a
Yeah.
very low maintenance
Yeah.
person when it comes to all of that. But I would like to know a little bit more about muscle loss during the perimenstrual menstrual period area.
Yeah, I mean, we have this natural sarcopenia, as you mentioned, this natural loss of muscle, which is not going to favor us when we talk about bone health, right? Because,
Yeah,
we
absolutely.
also in this perimenopausal or menopausal transition have the most rapid decline in our bone density, right? So we're having a decline in our bone density and we're losing muscle mass. Therefore, our metabolism is off, right? And we're gaining weight and we're frustrated. And so eating adequate protein, lifting your heavy weights. To date, I don't have evidence for the testosterone use supplementing that, but I can't think that in
Mhm.
normal physiologic doses that it would hurt. You said you like to keep it simple, you don't really like medication. So I have had individuals who say, you need to make this as easy as possible for me, right? They're business owners, they're professional, they're raising kids. They don't have time for this hormone therapy business. They don't want the overwhelm of their new hormone therapy regimen. So again, it's very unique to each individual what they're going to tolerate. But one of my favorite options for these type of women is to place a progesterone producing IUD and a
Mhm.
systemic vaginal estrogen ring that's going to take care of the hot flashes, the night sweats, etc. And it's super simple because you change that ring every 3 months and that IUD is in place for 5 years. So one of the biggest questions that I get though is, well, how long am I going to have to take this? Right? Well, that can't be good for me,
Yes, that
right?
was literally I'm like, do I have to do this till I'm like freaking 65 years or 70 years?
Yeah.
Please don't say yes
So
to
the
that.
short answer is, as long as you're feeling great and you don't have any contraindications, you can continue hormone therapy. It's cardioprotective, right? It protects us
Yes.
against fractures and bone loss. Like, we know that there are so many benefits. So hormone therapy remains the most effective treatment for vasomotor symptoms and genitourinary symptoms of menopause, and has been shown to prevent bone loss and fracture, right? So we know that it doesn't have to routinely be stopped at the age of 65. However, this is the common tagline that I hear from PCPs, right? I've got a lady, she's 65. She probably needs to come off her hormone therapy. I need to send her your direction. And I'm like, let her live, man. Like, if she is feeling great and she doesn't have, it's going to help. It's going to have those benefits beyond 65 if they're having persistent vasomotor symptoms, the hot flashes, the night sweats, the disturbed sleep. It's going to help with the genitourinary symptoms. It's going to help with bone loss. It's going to help with, we haven't even talked about like dementia, Alzheimer's. Like, if we have
Oh
started
yeah,
it
absolutely.
early in the 10 years of since your final menstrual period or before the age of 60, we have the most benefit for our cognitive health, for our heart health, etc. A recent study came out last month that looked at those who never used or discontinued menopausal hormone therapy after the age of 65 and the use of estrogen beyond the age of 65. And guess what they saw? A reduction in
Hmm.
mortality, breast cancer, lung
Wow.
cancer,
Mm.
colorectal cancer, congestive heart failure, blood clots, your atrial fibrillation, your heart
Yes.
attacks, and dementia. So hormone therapy works. Our ovaries produce hormones. This is a normal physiologic process to go through menopause, right? But we don't have to suffer through it. And if we know that replacing these hormones can actually be beneficial for our long-term health, I don't see any adverse, any reason to
Okay.
not give it a
You
try.
You briefly touched upon this, okay? So, and I want to kind of delve a little bit deeper into it. Breast
Mhm.
cancer. That's because that's been one of the biggest like contraindications, right? I actually started my career as a surgical resident, and my mentor was a surgical
Mhm.
oncologist. And I remember, talking about, oh, all these women take these hormones and they're going to get breast cancer, etc. But very recently, I spoke to a breast cancer surgeon who said breast cancer is a chronic disease these days. We can really easily detect and treat it. Let the person live. I would like to, you mentioned it causes reduction in the rates of breast cancer. Can you expand on that a little bit more, please?
Yeah, so the Women's Health Initiative scared everybody. They said it caused breast cancer, right? Though the average age of the woman in the Women's Health Initiative was not the average age of woman who was starting hormone therapy. The average age was around 63. So just let
Hmm.
that sink in. Okay.
Okay.
Secondly, it was not clinically significant in terms of the numbers of individuals who developed breast cancer. And it was only an increased incidence in those who were on estrogen and progesterone. Okay. Not the estrogen alone.
Okay.
Estrogen alone had a
Okay.
decreased incidence of breast cancer. Estrogen plus progesterone. Now, remember also that the Women's Health Initiative only looked at one formulation of estrogen and one formulation of progesterone. So
Okay.
we were
Okay.
looking not at the bioidentical progesterone that we are typically using these days, right?
Hmm.
And
Okay.
so in that
Okay.
study that I mentioned earlier, where they looked at individuals past the age of 65, some of that was offset with different formulations and different uses. So all are not created equal. The other big myth
Equal.
is, well, I can't use vaginal estrogen because I've had breast cancer. No, you can. There's no clinical significant systemic absorption. You absolutely can. This was my neighbor. She, just on the fly said, says, oh, because ever since my breast cancer, the weight, the dryness, all the things. And she finally came and saw me because she was like, wait, you mean there might be something I can do? Stage 1 breast
Hmm.
cancer, resected, like
Yeah, yeah,
stop suffering, and
yeah.
she is happily treated now. So this is such a common misconception that we cannot use hormone therapy if we've had breast cancer. Now, for
Breast
an
cancer.
active treatment for breast cancer, obviously we cannot.
I think I want to mention a caveat here because if there is someone who is listening to this podcast in outside US, that in the US we are pretty strict about the yearly mammogram
Yes.
or based on your risk every 2-year mammogram. So for anyone who is considering hormone replacement
Yes.
therapy, you have to be consistent with your breast cancer
Yes.
screening protocol also. They both go hand in
Yes,
hand.
it's
Uh,
whole health. I always say you're more than breast and pelvic exam, It is the whole
thank you.
health. And so yeah, I require that in my practice. Before I'll even initiate it, we have to have a clean mammogram, right? We have
Mammogram.
to
Yes.
investigate that. So I think that looking at the whole health is really important.
So one question, like if, I don't know whether you have patients in their late 60s and late 70s, does it go away? I mean, in the natural history of menopause, do these symptoms go away? And do we ever feel like, yeah, I don't know, 65, but no vasomotor symptoms and things like that? Does it ever
Yeah,
happen?
absolutely. I mean, there are a percentage of individuals who will have kind of a resurge of their symptoms when they come off, and that may be intolerable to them and they want to continue it, right? There will be
Hmm.
some people, even in their later years, who are symptomatic when they come off, more than just like this little phase of time, right? So there definitely are individuals who come off and who do just fine. There are individuals who went through the natural transition and say, oh, I don't have any of those symptoms anymore. But you know what really bothers them at this phase of life? Genitourinary symptoms, like their vagina is
Hmm.
dry, it hurts. Even when they wipe, they're getting fissures. It hurts to have penetrative sex, and they are fed up. And so vaginal estrogen goes a long way in that regard. That may be all they need is that local intimate skin therapy. They may not need the systemic hormone therapy. And certainly I have those type of patients. I have a lady in her 90s who sees me on the regular, and some incontinence, some was up all night needing to void, and had the vulvar irritation and constant vaginal dryness. And vaginal estrogen has been a lifesaver for her and kept her out of the hospital. She was going in with
Absolutely.
UTIs, getting IV antibiotics.
Thank you so much, Dr. Myers. I think you have personally taught a lot for me. This is like my own personal CME here. And I'm sure there are a lot of us female doctors who, haven't delved into this and probably, blaming our lives, our careers, and everything else for this. So thank you so much. I completely, thoroughly enjoyed myself. And I hope this podcast serves as a way for folks to actually find the therapy they need, and and what are the ways they can find you.
Yes, I just do want to say also that Estrogen Matters is a wonderful book by Dr. Avram Blooming, that is a great resource for those individuals who have questions about having a history of breast cancer, or does breast cancer cause estrogen? And he really goes through all of the details. It's a wonderful read.
Fantastic.
So that is a great resource. In terms of where you can find me, I'm at Dr. Carolyn Moyers on social, and skywomenshealth.com is my practice. I practice in the state of Texas and the Dallas-Fort Worth area. And I also host a podcast, Sky Women's Health, where we address a lot of these midlife health topics.
Thank you so much. It was a pleasure having you here, and I'm sure we'll bring you back for more questions.
Great. Happy to answer. Thank you so much.